Ability, Dr. Nattha Kulkamthorn, Pramukutka College of Medicine. Our next speaker is a very highlight lecture speaker.
I'm not a big guy for TTO.
Oh, yeah.
Okay. For all of you, my key message for evaluate the patient with the patella instability, you need to know the risk factors. The most common risk factors is trochlear dysplasia, patella aorta, high TT-TG ratio, and the thing is usually the patient have more than two factors. The first thing you need to know is more than two factors. 81% of the patient that have a patella instability have more than two factors. Why do you need to know that? Because you need to find out all of the factors and calibrate it to what to correct, what the factors need to be correct. The key that we could correct is about 7 VMO deficiency, lateral retinacular tightness, increased Q angle, root weakness, patella aorta, and trochlear dysplasia. Today we talk about two things that we could correct with the TTO, the increased Q angle and the patella aorta. If in case of patella aorta, you should do a patella TTO, that distalization and medialization or lateralization for the Q angle. Yeah, which factors that made the patella more dislocation? The recurrent rate is more than 33% if you have the trochlear dysplasia, the patella aorta, the age less than 18 years, TT-TG, distant and female sex. It's a picture of your patient. And the TT-TG is, somewhat controversy because you need to find where the place that you measure the TT-TG. So that's why another paper or another trend is go for TT-PCL distant. But you need to know if you use a TT-TG, it's more than 20. But if you need a TT-PCL, it's 24. And the patella aorta also, they have many measurements. The most common or most famous may be CD ratio. The normal is 1.2 or 1.3. And as I said, the TTO could correct the TT-TG and the CD ratio. That's we need to know and talk about it today. The surgical technique for now have three: the M3 triad, the Marquet, and the full cushion. Maybe for me, the full cushions is most common for me for correct this problem. For the when will we did only MPFL? Yeah, MPFL result that's not bad. Sometimes MPFL alone could not, as Dr. Cholatan said, the abnormality of the CD ratio or TT-TG more than 1.4 or more than 20. We could not use only the MPFL. So the TT-TG, why we don't use the TT-TG 20? Because if you use 15, that is above high normal limit. These papers show us about if you use 15, maybe overcorrection for medialization. So maybe 15 is not is overcorrection. Then how about the CD ratio, Ketong-Dechong ratio? What is the magic number for CD ratio? Maybe the highest CD ratio that we could not recorrect is a 1.4, because if 1.2 or 1.3, the MPFL that we usually perform with MPFL and TTO the MPFL could correct to be like a 1.1 or 1.2, because the MPFL could pull the CD ratio down. So the magic number for the CD ratio for now may be 1.4. If it's over 1.4, you need to be correct. The MPFL alone could not correct this problem. And also the CD ratio 1.3 with JSI is also a risk factor, but usually we perform MPFL with TTO. So for the TTO, for the CD ratio, I use a 1.4. The case, okay. Yeah, this case is a young lady have two patella dislocation in both sides. She decided to perform the left first. At first, she asked me, can she perform both operation? I said no, because he had a Ketong-Dechong is 0.9 and the TTTG is 25 and sulcus angle 136. So our plan is MPFL, TTO to medialization, and also lateral release, because the sulcus angle is more than 20. Oh. Why you okay? Why I could not see? Okay, how can I control? Okay. Yeah. We perform the lateral release first, and the TTO we perform a TTO first. And then we go for lateral release and the MPFL reconstruction. We use a Fulkerson technique. I could not control that. Okay. You see for the intraoperative, the lateralization of the patella. After that, we release the lateral side, and then we perform a MPFL. Yeah, we check the mobility. Yeah, first perform the TTO, then lateral release and MPFL reconstruction, and check the mobility. We should have a full flexion, full motion. After release, the patella go back to nearly normal, I have to say. Go back to nearly normal. And the X-ray like this, and the 1 year follow-up, or 6 months follow-up, the apprehension is better. But the problem of when you perform both procedure is stiffness. she got a stiff of the knee. She could not bend her knee for more than 90 degrees. So I have to go back for lysis adhesion. The adhesion is more on the suprapatellar pulse. Yeah, and release all 6 or 7 months after the first operation. Now, go for release and release the patella fat pad also. I mean the scar behind the fat pad, the infrapatellar fat pad. Yeah, after lysis, she got a full flexion. It's good for her and for me also. So the indication for TTO for now for me is patella ultra CD ratio is more than 1.4 and increased TT-TG distance more than 20 millimeter by MRI or CT, and recurrent patella dislocation with failed conservative treatment, severe pain due to malalignment and failed prior surgery. Tibial tubercle osteotomy is a good option for the patella instability. The TTO when I will do a TTO when the TT-TG ratio is more than 20 millimeter and ketone ratio more than 1.4. PF pain we will do a anterioralization, and for some case of revision MPFL or something. Thank you.
Any questions? One question.